Yeah, so thank you very much. Also, a warm welcome to the auditorium, to the people hearing us and listening us online. And it's a real pleasure to be here. Thank you very much, Jan. Within all the developers, software engineers, and I think I'm in the minority here, being a clinician. And you introduced us, we clinicians, we think different. And once I prepared this speech, I thought, well, I want to present you how we think as clinicians, and just to give you a small insight. So where do I come from? I also come from the southern part of Germany. I'm currently in a private practice in Schwäbisch Hall. We're connected to a hospital. So as we just heard from the speaker before, we're not a university hospital. We have smaller things in here. Co-beam CT is a working horse in our private practice. And I'm also situated in Heilbronn, so around about 2.5 hours drive from KLS World, where you're right now. What's the topic now? So within the next few slides, I'm going to introduce you a little bit into the field of orthognathic surgery, twin simulation, digital simulation within orthognathic surgery, especially focused on bimaxillary osteotomies and the RPE, the rapid patellar expansion. And I just want to go briefly later on, go on the CMF trauma and reconstructive items. We've already heard some things about it. So for those of you who are not so familiar with the clinical setting, what is orthognathic surgery? Why do we do orthognathic surgery? Basically, we have patients, and that's simply out of the last few weeks and months overview of patients with skeletal discrepancies. We have skeletal discrepancies in the sagittal, in the horizontal, and/or, so combination or singular, within the vertical dimension. And these patients have problems. They have problems with chewing with their teeth, and they have problems with their outer aesthetics. And that's, for me personally, as a doctor, the main focus why I want to treat these patients. Let's go a little bit back in time. How did we plan these kind of complex operations years ago? And I bet there are still some colleagues who do it like this still today. It's the topic is cephalometry. So before you start surgery, you have to have a plan. And before you start your planning, you have to check the basement. What is there? So cephalometry basically considers all the sizes, the locations, the ankles, and soft tissue structures. That's where the aesthetic later on comes in. And where are we now? Here's an image from the IPS case designer. We do bony and soft tissue analytics, all 3D, and I can all do it on my laptop. And that's the practical thing for me personally. We already heard some things about dental. So being an oromaxillofacial surgeon, also in the field of implant dentistry, orthognathic surgery, aesthetic surgery, we're very familiar with intraoral scanning, with planning crowns and all that stuff. So we also use these tools, also small 3D printer. We have this in our private practice because it's fast. You print it and in 1.5 hours, you've got the item in your hand. We do intraoral scanning of our patients. We can't print the casts if you really want to have something in our hands. I'm not that old-fashioned surgeon, but still in some situations, I really want to check this, having something in my hand, and then scanning it again and bringing it to the planning software. You can also use face scans, a lot of different stuff. But we also can do the whole thing digital, of course. That's where we stand right now. This is when I show you my personal workflow, how I work every week. For me as a surgeon, when a patient comes first to me and they simply have a kind of informative speech with the patients, we don't talk about surgery appointments the first time the patient comes into my private practice, but the patient wants to inform himself, what are we going to do? He read something in the internet, he saw some YouTube videos, and the patients are scared. That's the first emotion all of these people have. And the thing is, I as a surgeon have to have a really precise plan. Where and how can I move, for example, the jaws, if we're in the field of orthognathic surgery, and get the best outcome in the end? And we live in social media times, so people post their pre and post-op pictures everywhere. And this is, for me personally, one important item why we need digital planning, also for showing the patients the one or the other thing, just for understanding and give a better understanding to the patients. So digital twin planning, we can do the movements in the orthognathic sections. This is, as I mentioned, our working horse. And then comes the second most important thing. And this is actually for me more important than the planning, because as I showed you, planning is standard more or less to a certain extent. But how can I accurately transfer my planning I do on my laptop into the OR? And this is still a task which I personally think there's lots of potential available. Because if you just look on these images, on these two movies, you can move the upper and lower jaw in each and every direction. And there are lots of pitfalls during an operation. One small bony edge here, one small bony edge there, and the whole dimension of the jaw, the maxilla, the mandible might twist, turn, or be just a small, non-accurate way situated within the patient. Some clinical pictures, as I said, we think different. We show all other stuff of pictures. So you see on the left side, the maxillary osteotomy, see some plates and screws in there. You also see some wires because we fix intraoperatively these patients with their maxilla and mandible to really get a proper dental occlusion, as we call it. And on the right picture, you see the left side of the mandible split. This is typical J form. And this is all done intra-orally, so no extra-oral incisions. So how can we improve the transfer in our OR? And this is what we did recently. We transferred our STL files from the planning software, the IPS Case Designer, into our brain lab system in the hospital. This was simply by coincidence that the hospital, the Diakoneo Klinikum, just got a great gift, to call it. And we had the opportunity there to get access to the CBCT scanner in the OR and the intraoperative navigation. So what was the setting? On the left side, you see the patient. For intraoperative navigation, you need a star when you do the registration. And on the right movie, you see the calibration of the CBCT scanner intraoperatively. So all stuff done before the operation by the team. And then we as a surgical team come in and do the operation. And what is the advantage for me personally? First, the intraoperative navigation. I can transfer the STL file into the CBCT scan here. And you see it in the lower right picture with this kind of pencil you have. You can intraoperatively check your, in this case, maxillary position, new maxillary position, where you want to have it, and is it there where you have planned it? So red is the planning, and then you have the pencil, put it on, for example, teeth or the nasal spine, as you can see here, and you can intraoperatively check, for example, is the anterior movement enough, or is there some kind of problem? And second, you can do the intraoperative CBCT scan, and for example, considering the condyles, you can just double check if the pre and now intra-op, so almost post-op situation is exactly the same. Have we any further problem, or can we just finish the operation like this? And for me personally, this is one item where we could increase our accuracy intraoperatively, but of course, the whole teamwork, the whole work done around this operation is not daily routine. It just takes too long if we do that with each and every case. This was a patient we operated with this intraoperative scanning after 3 months and the pre-op picture. So let's go to the second item within orthognathic surgery, the rapid penile expansion, the RPE. We already had it in a session in the workshop in this morning. What does rapid penile expansion mean? It's a kind of osteotomy, majorly in the median line, to shift or to drift the two sides of the maxilla to the right and the left side, and to increase the transversal width of the maxilla. The indication, the deficits in the transversal width, and the open bite is the most open indications. Why we do these kind of operations. So what's the RPE in precise? We have an asymmetry in the anatomy. We have an osteodistractor, the RPE device you see in the upper right picture, and this device is simply a kind of double screw, and it gives constant forces to the right and the left side. And we as surgeons are there to symmetrically weaken the maxilla in the upper part so that the opening of the maxilla can take place. And sometimes we even get a kind of asymmetric opening. So the prediction of these kind of operations are not 100% exactly as we do it in old-fashioned traditional manners, so to say. And you see here in this slide just an intraoperative case as well. From a mechanical point of view, if you drift the maxilla to the right and left side, there might be some kind of bony obstacles. That's why we take these small wedges within the maxilla on the lateral side out, so that they really can drift apart. And we intraoperatively, by simply activating the distractor a little bit, just check so that a certain symmetry is there. So if the osteotomy is well loose enough. But sometimes we've got special cases. And this one was one case we did with Simq, the asymmetric RPE. So why? We see here on the left side this patient, and that's the model of this patient here, presented with a complete midline shift. So the upper incisors drifted much more to the right side compared to the lower incisors in the mandible. And also we had this unilateral crossbite. It was a young lady, 21 years of age. And within this special asymmetry I thought, well, the traditional way of doing an RPE might end up that the right side might even drift further away, although it's actually in the right position. We actually, as surgeons, only have to do something in the left side. And this is how it came out. And we did the simulation with the distractor device. And in this case, the theory was we do an asymmetric weakening. We have the symmetric force of the RPE screw, and then we hopefully get a symmetric result in the end. And this is also the intraoperative pictures here. We use these guides. This is one of these standard guides we have nowadays. And we usually do this operation with piezo surgery. So you find lines of osteotomy in an asymmetric, incomplete manner. This is the vertical osteotomy going between the second and the third teeth. So the canine, mesial to the canine on the left side. And we also position the screw with the help of this guide pointing us the fixation points on the panel side, so that we really get a precise vector how the screw is opening. This was a simulation preoperative, and last week I called our orthodontist who's treating this patient. It was around about 3 months ago. We took out the distractor, and we now have the 6-month post-op results, and we're pretty much in the range where we expected. And this is also the intraoperative oral scanning, so midline of the incisors, although the patient is still on the treatment, is already done. Then one last slide to trauma and reconstructive surgery. We already heard some things here of educational aspects we can have in these special personalized implants, patient-specific implants, and the planning going along with it. For me personally, as a surgeon, the biomechanical evaluation, if I really order one of these very expensive, so I'm a Swabian in southern Germany, we live on the money, very expensive things here, the biomechanical evaluation is very important. So if I order this, it has to be stable, it has to fulfill its job, otherwise it's crap. Yeah. And of course, maybe the simulation might show that we should choose a different kind of plate, thickness of plate, type of plate, okay? Pre-bending, yes, we could do it. Individualization, yes, in special cases, because what I have to keep in mind, and I will address it completely at the whole auditorium, it's time consuming. I did 3D planning, IPS case designers once I was in the university hospital. It's nice, yes, it's learning. And as a young resident, we get used to it, but it's time consuming. And if you're in private practice, you have your whole day full of patients, you have to do it in the evening. And there are not more any software developers or planners after 7 p.m. available. And of course, it has to be cost effectiveness. We drift into an ambulance setting. US is more or less lots of ambulant operations, and in Germany, healthcare system is at the moment changing. And please keep this in mind, because developing things is nice, but it has to be paid. So take home message, twin simulation, very good thing, increases accuracy and predictability for our patients, of course. We have to improve the transferring process in TDOR. I just showed you one method. For me personally, it's only a tool for unusual cases. So the usual stuff, I do this without any simulation. Major discrepancies, major asymmetries, of course. But the cost and the time, they have to be taken into focus. Thank you very much.